Hi, my name is Kate, and for my specialised pharmacy practice, I've chosen to conduct an antimicrobial audit at the Mercy Hospital. Um, Firstly, I'll talk a little bit about the project. It was conducted in Mercy Hospital, as I mentioned before. It is a private hospital located in Mount Lawley. It has a small 205-bed facilities which provides overnight hospital treatments, day treatments, mental health facility, and also recovery units. The APHS pharmacy is a privately contracted pharmacy located on the ground floor of the main pharmacy. They are responsible for providing all the medication throughout the hospital, and these are people that I worked with for the last month. So my project objective is to conduct an audit and to find out the compliance of the antimicrobial guide prescribing at Mercy Hospital with the current Australian antimicrobial prescribing guideline. So the audit I conducted is a part of a antimicrobial stewardship program. This program is basically a collective set of strategies to improve the appropriateness of antimicrobial use and also to minimize the adverse effect. This includes resistance, toxicity, and also cost to the governments. So stewardship is achieved by promoting selection of optimal antibiotic regime, dose, duration, and route of administration. It started in 2011 and since then has been included in the Australian Commission on Safety and Quality and is one of the compulsory criteria of hospital accreditation process. So there are about 5 essential strategies. Firstly is implementing clinical guidelines that are consistent with the latest version of therapeutic guidelines. They take into account to local microbiology and antimicrobial susceptibility patterns. Secondly, is to establish restrictions and approval system that basically restrict the broad spectrum and also later generation antimicrobial use. Thirdly is to review the prescribing patterns and give direct intervention to the prescribers. Fourthly is ensuring clinical microbiology laboratory use. It actually reports the susceptibility testings. And lastly, which is a part of my project, is monitoring performance of antimicrobial prescribing using ward-specific data, auditing antimicrobial use, and use quality use of medication indicators. So firstly, the first week I've actually produced a collection data. This data will include patient's MIU number, which if I need more information of the patient, I can go back a bit later, find the MIU number, and go back to patient's file. Secondly, patient's age and weight. Age and weight are quite important when it comes to determine how much of antimicrobial use. Thirdly, the reason for admission. And lastly, I've also included the type of cephalosporin used during the hospital stay because that's the main group of antibiotic I was focusing on. This also included the route, the dose, the frequency, and the indication for antimicrobial use, such as empirical, prophylactic, or directed. So this audit was conducted in a single centre, Mercy Hospital, a blinded control study, and during the month of August 2013. So again, as I said, the audit's particular focus on the cephalosporin group of antibiotics because that was mostly frequently used, and that's the one I was focusing on. Patient including the audit are recruited from the main part of hospital, which is day surgery, 3rd ward and 4th ward. Most of the information are gathered from patients' medical charts and medication files. Basically, I just go through the ward, go through the medications, and include that onto my data sheets. So I followed the Australian Therapeutic Guideline, which is the electronic version. I also use Australian Medicine Handbook as a reference and also Antimicrobial Stewardship also as a reference. There's also criteria that patient must meet to be included in this audit. Firstly, the patient must be 18 years and older. Therefore, I did not have to get permissions. Secondly, they are admitted to the Mercy Hospital during the month of August 2013 and receiving cephalosporin treatments for either proven, suspected, or prophylaxis dose. Maternity ward, MSU, which is a restorative unit, FSU, mental health wards were actually excluded in this data due to restricted access. During the 3 weeks of data collection, I've collected a total of 54 patients' medical records. These patients that were recruited are generally from orthopedic, gynecological, and abdominal patients. From these data, it was found that only 4 cephalosporin were used. They were cephalexin, cefazolin, cefalothin, and ceftriaxone. So cephalexins usually can be used for both UTI and also prophylaxis. Cefalothin and cefalothin were mainly used as surgical prophylaxis, and ceftriaxone used both as treatment and also prophylaxis. The commonly used antibiotic in Mercy Hospital were actually cefazolin and cefalothin as for surgical prophylaxis for both orthopedic, gynecological procedures, and to some extent some abdominal surgeries such as hernia. During the 3 weeks of data collection, I've collected a total of 54 patients' medical records. These patients that were recruited are generally from orthopedic, gynecological, and abdominal patients. From these data, it was found that only 4 cephalosporin were used. They were cephalexin, cefazolin, cefalothin, and ceftriaxone. So cephalexins usually can be used for both UTI and also prophylaxis. Cefalothin and cefalothin were mainly used as surgical prophylaxis, and ceftriaxone used both as treatment and also prophylaxis. The commonly used antibiotic in Mercy Hospital were actually cefazolin and cefalothin as for surgical prophylaxis for both orthopedic, gynecological procedures, and to some extent some abdominal surgeries such as hernia. So let's talk about a little bit of the compliance. The compliance for the antimicrobial use, which I found was actually 76%. Most of the non-compliance actually occurs in orthopedic patients, with 7 cases of non-compliance, and the rest of it were actually made up of the UTI treatments. So in the orthopedic patients, the non-compliance actually occur mostly in larger operations such as total knee and total pelvic surgeries. Patients are often on more than 2 surgical prophylaxis, where the first dose will be a single first generation cephalosporin during the induction, so 30 minutes before the operation, and second one would usually be after the operation, lasting from 24 to 76 hours. And some practitioner will also add on another broad spectrum ceftriaxone dose at the end of their antimicrobial therapy. The reason I've labeled this as non-compliant is because there is a lack of evidence suggesting the use of more than 2 surgical prophylaxis in orthopedic surgeries. Usually you can use a second dose after the surgery if to prevent staphylococci infection through the skin flora, but no more than 24 hours. There are also very little documentation for the antimicrobial prophylaxis dose, which made it harder to determine the indication of use. Again, so I had to label this as a non-compliance. So when I brought the query regarding the use of ceftriaxone to my preceptor, her thoughts were the ceftriaxone were actually used during the removal of urinary catheters to prevent any more infections. This was not indicated in the therapeutic guidelines, and when I looked into a bit more in literature studies, it was actually still suggesting antibiotic prophylaxis should not be more than 24 hours, even in the case of removing a urinary catheter. So in conclusion, effective antimicrobial stewardship program has been shown to improve appropriateness of antimicrobial use, reduce patient mobility and motility, and also reduce institutional costs and bacterial resistant rates. Therefore, appropriate use of antibiotics should be reinforced, especially in this case in the orthopedic surgeries. Thank you very much.